everyone. Welcome to another episode of the Registry Exchange, the series where we bring registry professionals together for engaging conversations, expert insights, and timely discussions on industry trends. Thrilled to be your host today.
And I'm Karen Mace, and I'll be your moderator. I'll be working behind the scenes. So if you guys want to comment or have questions for any of our panelists today, just comment in the chat. I also posted a poll there in the chat, so we'd love to have you participate there so we can have some more engagement during the live session today. So thank you for joining.
Definitely. So today's live stream is one that Karen and I are really excited about because registry data analytics are unlocking new opportunities for better care, better planning, and ultimately better outcomes for patients. So our discussion today brings together three incredible leaders in this space. We have Laura Close from the Medical University of South Carolina, Erin Barris from Corewell Health West, and Leslie Woodard from Franciscan Health. So thank you all so much for being here. But let's give each of you. So Laura, would you start us off, and then we'll go to Erin and finally Leslie.
Sure. Thanks, Erin. I'm Laura Close. I am the System Director for Quality and Safety for Cancer Services at the Medical University of South Carolina. And I have been an oncology nurse for just over 20 years now. I'm very new in the registry space. I have been manager over that program for the last 3 years. So I'm not a registrar, but have definitely spent a lot of time with the team learning about the registry world. So excited to share my perspective today.
And then I'm Erin Barris. I am the manager for cancer compliance and data at Corewell Health in the West region. We are a large health care organization in Michigan. We have 3 regions, our East, South, and West, and I oversee our registry team in the West. I am even newer to the registry space, though, as the manager for the cancer registry team. I started my position in February of this year, so helping the team and then overseeing our COC and NAPBC accreditations at this time with NAPRC, and then also FACT accreditation for BMT coming under my purview in the next few months.
And hi everyone, I'm Leslie Woodard. I am the tumor registry manager for Franciscan. We have 11 hospitals throughout Indiana and Illinois. So I oversee all of those, all the registry aspects, assisting with the COC, NAPBC, and NAPRC accreditations at all. I've been in the registry for nearly 12 years and do hold my ODS certification. Additionally, I am the Indiana Cancer Registrars Association Education Chair, so many of you may have seen me through some of those quarterly webinars. Thank you for joining us today.
Thank you guys for joining us too. So to kick things off, we did ask everyone joining us today to complete a few poll questions ahead of the live stream, just to help us gauge where you and your facilities are at in your data analytics journey. If you haven't had a chance to fill that poll out yet, please do so. Karen will put the link into the live chat on the YouTube side. And so you'll have a few minutes left to get your answers in, and just keep an eye out for that. So again, we have a rich conversation ahead of us today. We'll begin with some foundational uses of registry data, then move into a comparison of concurrent versus retrospective data. And then from there, we'll explore how data can drive decisions and outcomes, and also address critical issues like equity and bias. And then we'll just close out by looking ahead at future innovations and finish with bring back to your own registry. So similar to last time, because we are live streaming, there is about a 30-second delay from what we're doing here live in our call versus what you're seeing at home or at work. So please just keep that in mind. If you're asking questions in the chat, we may move on to something and then have to just backtrack a little bit because we do see your questions then. And that's totally normal. Still, we definitely want you all to be have an interactive conversation. That's what we're here for. That's what this panel is for. So again, feel free to ask the panelists any questions at any point during the roundtable. And we'll also be showing some prompts on screen, just like last time, to help keep that conversation going. Again, the purpose of the Registry Exchange is to make sure you walk away with the most relevant insights to strengthen your own registry. So, Karen, do we want to go ahead and look at the first poll question, which is, how familiar are you with how your facility uses registry data analytics? So we do have a little bit of a tie, 42.9% of somewhat familiar and very familiar, which is fantastic. But then we do have a couple of responses of not involved in analytics at my site, and then also not sure. So to build off of that, we're going to turn to our first topic, which is the foundational uses of registry data. And that's essentially how we're applying data in practice and what it means for patient care, quality improvement, and research. And registry data really sits at the core of so much of these decision makings in healthcare. So then, Karen, we have the second poll question, which is, which area does your registry data support the most? And then we'll get into talking with our panelists. I think we have to skip down one. There we go. So the big one, not surprising at all, is accreditation and compliance. We all know that we have a lot of reporting to do, the National Cancer Database and RCRS, to really get information submitted out there so that it can be used nationally, and then also the quality measures. The next top response is not sure, not currently used. And then we have a few for quality strategic planning, so that's wonderful. So I'm going to ask the panel then, how is registry data typically used within your guys' health system? And just feel free to hop in whenever you want.
So I'd say we do use it a lot for accreditation purposes, of course, but the largest area I see is strategic planning. I get constant data requests, and we use them for so many different things. So new FTEs, justification for that. And not even just within the registry, but anywhere within the cancer center or imaging, areas like that. We use it for clinical trial feasibility, marketing data, and just recently, as yesterday actually, I got a request about the number of colon patients who had surgery and adjuvant chemo, because our rehab department just found a research article that talked about how a structured exercise program has really helped the outcomes of those patients. And they were trying to see if that's something that should be started in our program, based off of the number of colon patients that had surgery and adjuvant chemo.
I would say we're also along the same lines as what Leslie is doing with her group. We get a lot of data requests for a clinical trial feasibility, but we also have a good number of clinicians who want to use the registry data for even just QI initiatives. So they're looking at some of the aspects of a particular patient population and just seeing what they can do from a quality improvement perspective outside of the research space. So I think that's always really interesting to see what they're requesting and what they come up with at the end.
Yeah, definitely. Erin, what about you guys at Corewell?
Yeah, I would say mostly it's looking at how we can support FTE based on the growing number of analytic cases that we have at our site. Additionally, we're looking a lot more closely at our in-migration and out-migration to identify any potential trends for strategic projects and goals.
Definitely. And just through my experience too,
Yes,
I've seen a lot of the same thing. So patient care and clinical management, so such as tracking treatment outcomes, or even time from diagnosis to treatment, or treatment to treatment, like neoadjuvant systemic therapy to surgery. And then of course the big one, the in and out migration trends to help plans, like staffing, equipment, or support programs. Karen, is there any chats yet in the audience? Okay. If we do, just throw it up on the screen and then I can talk about them, and we'll do that. So guys, definitely if you have any questions or want to share any of your insights, please do. So really the next step in data analytics is figuring out how to take those uses of registry data and translate them into something clear and impactful. And really one of the most common ways to do that is through reports and dashboards. So to our next topic, which is showcasing the power of registry information. So to the panel, how do you all go about demonstrating the value of this data and even communicating its importance to key stakeholders like your physicians or administrators?
I can start with that one. So we actually, and I know this is the case for a lot of registries across the country, but we have struggled with that for a while because for probably ever since the beginning of COVID, our registry just fell behind and was, multiple years behind in our abstracting and reporting. And so I think our organization unfortunately lost a little bit of faith in the registry data and in the ability to use it to make real-time decisions. It was great for looking for retrospective research studies and perhaps even just potential trial populations, but to use it for anything sort of real life was a challenge. But we have been lucky enough to get caught back up. So I think with over the last couple of months, we have really gotten to a place where we are almost concurrent for all. Gosh, how many do we have? I can't even remember. I think we have like 11 different facilities that we're collecting for. And so I think my goal now is just to be able to highlight the fact that we have more current data to be able to get people excited about it again.
Definitely. What about you, Leslie or Aaron?
Yeah, it would be very nice to be as caught up as Laura. we are not there, but our data is still, I mean, historically there's ups and downs and some changes here and there, but we're at least at a point where the data is usable. The thing is getting it in the right hands and just making people aware of what we do have available. So we do use Cancer Committee sometimes to provide different information. That's, of course, a lot of the accreditation data, what comes out of RCRS. Luckily, that is more concurrent now than it used to be, but still letting them know that we can run anything that we have in the database on that. So as far as much concurrent as we are. And not just, I mean, you got to look at who you're sending it to. You can't provide a whole bunch of data or without explanation. Pivot tables are very helpful. That can give you a lot of information, but a very quick snapshot of it. So the other thing is having someone on your side. So here, my director is great. He promotes the registry a ton. And has actually been putting people in contact with me from other departments to say, hey, Leslie can give you this and this. So getting that word out there of what we can provide has really increased my workload.
In a good way, hopefully, but
yes.
It's good that you have someone in your corner kind of almost like fighting for the data and just letting everyone know, hey, this is what's available. This is what we can pull. We capture almost 1,500 different areas and codes of data. And so we need to be using it more. But Erin, what about your thoughts from Corewell?
Yeah, we have a fantastic business intelligence analyst on our team. So she knows how to do all kinds of coding and does an amazing job with visualizing our data for us. So we're just starting to get into this a little bit. So we use our registry software, download the Excel spreadsheet, and then we're working through how can we automate some of it, and then how much can we use from our software. So some interesting visualizations are in the works right now. So
that's awesome. Yeah, and I know one thing I've learned too, as far as communicating its importance to different stakeholders, is you almost really need your audience. And I think you talked about this briefly, Leslie. But physicians care about different things than like administrators do. So, physicians are looking at clinical relevance, so better patient outcomes, streamlining workflows, access to data that's supporting evidence-based care, while administrators are looking at more of the operational efficiency, cost effectiveness, that accreditation, and even like the reputation of the hospital itself. So that's just one thing I've learned over the years with presenting data to various people. And then also to demonstrate the value, starting small and then scaling up. So when you're starting to introduce this data to your stakeholders, pick one or two impactful initiatives, something as simple as improving timeliness for treatment of a lung cancer patient or breast cancer patients, and then show some of those measurables from the cancer registry, and then start building from there. But kind of looking ahead through everything, how do you all see cancer registry data shaping the future of cancer and even treatments?
So I can start. I mean, we use it already for our cancer prevention and cancer screening events. If the data does show us where to focus. If we have a site showing up with a lot of late stage disease, then that tells us, well, let's focus on some prevention and screening efforts on that specific site. And then the other thing, just make sure your data is accurate, because there is a lot of work that's going to be put to use with what you provide. So the accurate data is so important for researchers. The clinical trials they're working on, I mean, they use our data for that. So to work towards preventing future cancers or coming up with new treatment options.
Perfect.
Yeah, sure. So I think one of the other things we're using it for, so our health system covers the entire state of South Carolina. We have hospitals and clinics everywhere, and like most large health systems these days, we're looking to continue to expand. So I think one of the things our registry data has allowed us to do is look at the volumes of different cancer types within the different regions of the state and know which specialties we need to onboard in those new clinics as we're opening them, eventually getting to where we offer as many as possible, but we may start with, lung up in the old tobacco farming part of the state and prostate somewhere else based on our registry data. So that's been a really interesting use case for it.
Definitely. What about you, Erin?
I would say that this is actually probably an area of opportunity for our registry data, is to really help. We have an extremely robust community outreach program, very active in the state of Michigan. We have 2 mobile buses, or we have 1 mobile bus, just got approved for a second mobile bus to go out into more of our regional rural spaces in Michigan and possibly beyond. So very exciting. But I think we have a lot of opportunity here. So I'm excited to hear what everyone else on this call has done. So it's been a very great learning opportunity for me being new to this space.
That's great. Yeah, we're all here to help each other. I know for me, I almost feel it is starting to move beyond just being like a passive record keeping tool. It's really starting on the facility level to become really a strategic driver of innovation. It's enabling prevention programs that we can target. So target our colorectal patients, or targeting our lung cancer patients, or prostate. And really diagnoses are becoming more timelier and more accurate because of those prevention and screening events as well. But really, we have to think of it too on large registries like SEER or the National Cancer Database that are tracking our data for millions and millions of patients. And without that data, we would just have small selective snapshots from clinical trials. And our data too shows survival trends across diverse groups, not just those trial participants. So, I mean, still, when you see statistics and quotes like early stage breast cancer has a survival rate of over 99%, that's based on the millions and millions of patients that our individual facility registries have submitted to SEER and NCDB. So it's really, really exciting to kind of look at it on the facility level and then on the national level as well. But for you all, beyond what's already happening, where do you see the biggest untapped opportunities in registry data analytics today?
I think for us, simply, it's just the story that the data tells about new cancer cases in our system.
Mm-hmm.
Yeah, not everyone knows how detailed we get in the registry, therefore not knowing what data to ask for. So I think registry managers need to be involved with more, or communicate and share the different data that's available, so it starts being used more internally.
I'll just echo the same. I think it's a lot of just sharing and really getting ourselves out there, because there's a lot of amazing work that's happening and a lot of robust and rich data. And not even just within our healthcare systems, but even for our state reporting. I think we could get involved even on a bigger, broader scope. I'll leave that there, though. It feels like a big topic.
So we do have a question for all of you guys. So this is from Aaron. Hello, fellow Aaron. Someone mentioned using a pivot table to share data. Can you give examples of what information do you put on a pivot table, and what does the presentation discussion look like? So I believe, Leslie, you had mentioned the pivot tables, but I know, Laura, I'm sure you do as well, Aaron. So whoever wants to jump in and take over that.
I can do it. So I just did one this morning. And so I pull a whole bunch of data out of the registry, the sites where, let's see, I'm trying to think of the one this morning. It was about breast reconstruction. So in the pivot table, I provided the year of surgery, and then would provide the number of cases that had reconstructive surgery, and then the facility. So it's just a real quick snapshot of showing, how many patients had breast reconstructive surgery and what facilities were they done it in our area. And then we broke it down from the reason for this was to show that there is need for more plastic surgeons at our facility. So that's just one example. There's so much information that can be added to them. And that's where I just add, like, if I'm just sending the data to my director or whoever requested it, then I'll explain how much more is available there. Like, if you expand the fields, and then it'll show by which surgeon, if they're wanting to see how many surgeries each surgeon did. That's just a very quick and easy one, but they can get much more involved than that. I don't know if Laura wants to speak to any that you've done.
I'll just say, without delving into it all, I think part of that question, I think, was how do you present it? How do you incorporate it into a presentation? And so I think it, as Aaron mentioned earlier, like, it really depends on your audience. What was the question? What are you trying to get across? And so when we have maybe a researcher do a data request, we usually just kind of give them all the raw data and maybe a couple of pivot tables, because we know they're going to be able to manipulate it. Versus, I had one of our thoracic surgeons ask me for something recently, and we did our normal, like, here's the raw data, you can do something with it, and she just did not, like, that was not her wheelhouse. And so we had to go back in and kind of create the tables and say, okay, and I just summarized it in the email for her too. Here's the number of patients who had surgery, here's the number of patients who refused, because that's what she was looking for. So I think it really depends on who's asking the question and what they want to know, and where that information is going to be shared.
100%.
Definitely.
Could not agree more.
Yeah, and there were a few people in the chat already saying they love using pivot tables. Some of them are using it for time to treatment, which I've used them for a lot as well. So if you guys don't know how to do pivot tables, we will have a resource at the end for you guys too, on some intro to Excel courses, and then also some data visualization. So that we were talking about that before, presenting to your audience, what type of graph would be best used for different type of data. So we'll have that for you all at the end as well. But for right now, so we're going to kind of segue back over to looking at that, or just talking about prospective data. And Karen, we did have a poll question on that. So how close to real time is your data abstraction process? And about 50% of people are at more than 6 months, followed by within 6 months. So that's kind of where we see a lot of registries today, within 6 months or even 6 to 8 months. We do have a few that are within 3 months. And thankfully, no one said we don't currently track this. That would be very hard to keep track of your data for sure. So, and same month also would be a little bit hard. So this is about where we expected everything to be. Thank you, Karen. So you guys, so Erin, I'll start with you. What is everyone's perspective on the importance of concurrent data?
Yeah, so I feel that concurrent data really helps monitoring real-time improvement efforts to see if we're changing a process the way that we truly intended to. So this really ties back to short-term and short-term goals, and then our efforts to modify our long-term outcomes, and which is what will translate back to our data with our cancer registry. So prior to my role with Cancer Registry, I worked in stroke and was pretty familiar with Get With the Guidelines and Joint Commission standards. And so I very often compare experiences. And so I look at what we're doing in our Cancer Registry we're a little bit behind too. So we're 3 for 3 for what it's worth, if that makes anybody feel better on the call. But really tracking some of the concurrent processes. So I think of standards 5.3 through 5.6. We're tracking and auditing those synoptic op reports and providing feedback in real time. And then that way we can work through documentation habits and then ensuring we're being compliant with guidelines and best practice.
Definitely.
I mean, I think Erin hit everything. I don't know that I have anything to add to that.
Yeah, I think the only thing I could add is just how I mentioned earlier that for so long our registry was overlooked and yet underutilized because of its latency, that, you know, we're working on the campaign to get people to trust it again and want to actually use the data.
Definitely. And even some people, this has been, if you ask any registrar or even say the term concurrent to a registrar, you can get into a very, very long discussion. I'm sure, Leslie, you can be included in that as well. But concurrent doesn't really necessarily mean like to the day or even to the month. I know registry partners for accredited facilities, we recommend they be within 3 to 4 months concurrent, so that we're still within that 6 month time frame, but also we have a little bit more real-time data that we're submitting to RCRS and seeing those updated quality measures and having data available for our physicians and committees and things like that. So don't feel like your registry has to be within the day. They're just at diagnosis if you're doing it within the day, and then you have to touch the case 10 times or something like that. So we'll talk about that more in just a little bit, but I just wanted to bring that up. But so for you all, with getting a little bit more concurrent or even still being a little bit behind, what have been some of the challenges or limitations that you faced in trying to make that shift to being more concurrent?
So
yeah,
Laura, you can go first.
Sorry. I mean, for us, I think it's just one of the other things that we've had is limitations on staff that can actually like pull the reports, because you all know better than I do, but registry data is so nuanced that it's not the most user friendly, and so that that kind of presents its own challenge. It's not really a self-service tool, and the historical delay in the data and the perception of it being outdated means that the institution hasn't really been using it to accompany the clinical data.
So, I mean,
definitely. And Karen had put on there,
no,
sorry, really quick, that Erin had said the term concurrent gives her heart palpitations. Yeah. And I definitely agree. And I think probably Leslie agrees too. Yeah. So sorry, Leslie.
No, you're good. I saw that and I did laugh when I saw it come through. I mean, I'll be upfront with you guys. We are not concurrent. We're not where I would like for us to be. And when I think of it, it dates all the way back to 2018 for us. Of course, that was a huge transition year for registry. And on top of that, we threw in a change in software in the middle of it all. And that just really got us behind, because we were within 2 months really before all of that happened. And now, you know, our top sites are closer to that 6-month mark. But our others are more like a year, which is really sad to hear. But we are working through that. But the reason that it's still like that is just limited FTEs due to hospital budget concerns. I mean, that's nationwide.
Yeah.
And then delayed software updates. Yeah, this year was definitely better than years past, but the delay in the software, I mean, if you're not getting software updates until June, you're having to revisit cases, you're having to hold a lot of cases, so that doesn't help with becoming concurrent.
Right, and especially when the state won't accept them until they've upgraded everything. So there's always that like first 6 months of every year where we're doing cases but leaving them incomplete and just kind of waiting for everybody else to catch up. So Erin, do you have anything?
I really think Laura and Leslie hit on most of the things I was thinking about. I will say I'll throw this out there that if we're not documenting in a consistent place within the medical record, or if we're not using extractable fields, even sometimes that can make things even more challenging. So yeah, I'll leave that there, because physicians are fantastic, but it's really hard to change their habits. And the idea of documenting in extractable fields, I think, probably gives them heart palpitations.
Right. Definitely. And I've given a few talks to a few different state registry associations and things just on how to get your registry concurrent. So I won't go into all of that because that's an hour talk all on its own. But one thing I'll leave everyone with before we kind of move on is definitely come up with a plan to become concurrent. It's going to be hard to just sit there and try to get through as many cases as possible without actually sitting down and looking at what's the number of cases in your backlog, what is the number of cases in maintenance, and then trying to figure out FTEs from there. If you're able to present the plan to your administrators, you're more likely to kind of get their attention and possibly some extra budget to get the staffing that you may need to get to concurrent if you kind of sit with a plan. So if you've seen the talk, great. If not, definitely reach out to me on LinkedIn or email me. It's just erinweber@registrypartners.com. And I'm happy to kind of share some resources with you guys. But back to the conversation. Do any of you feel we are overestimating the value of analytics if the underlying data quality is inconsistent or even sometimes incomplete?
I absolutely, short and sweet, absolutely. But one example that we have, our EMR has a cancer registry feature built into it, but we've never been able to use it because we can't really validate the included data. And it goes, it took us a very long time to understand why we couldn't use it. And it really goes back to what Erin was just talking about documenting in the discrete fields. And so that, because our physicians don't want to do that, that renders that tool unusable. And so, we know what the problem is now, but the workflow still isn't there to support the functionality. So we're still not using it. So I know that's not, registry specific, but it aligns, I think.
It impacts the work, that's for sure.
Mm-hmm.
Definitely. Anyone else have anything to add?
I think it just goes back to my point earlier of data quality being very high quality. And that's something else that we push at Franciscan, which is another reason of leading to not being concurrent.
Yeah, definitely. I mean, the value of any data analytics is only as strong as the quality of data that's underneath. And then inconsistent or incomplete data can really distort findings and lead to misguided decisions. But really, when used together, analytics can highlight data weaknesses even, which in turn can drive improvements, making your entire system stronger. So it really is important, but just being aware of incomplete data or cases, depending on how concurrent you are, make a difference. So then really, once these challenges are identified, how would you approach cleaning, validating, and linking cancer registry data to other data sets?
I can kind of, tap into my answer for the last question. So one of the maybe sort of pie in the sky solutions that we came up with is trying to combine our registry data and our EMR data so that we can kind of have as comprehensive of reporting as we would really like to see. We've attempted to use the EMR to import some of the abstracted data, but the vendor isn't really willing to support us on that. So we're shifting and trying to do it outside of that, just in a, I don't even know, some sort of analytic tool that is far beyond my capacity, but really pulling all the data and using. So what we want to do is use the identified cases from the registry as our denominator, because forever we have not been able to define our cancer patient population within our EMR. So we can't use that as a denominator to use any of the sort of out of the box reporting that they have. So we're going to try to kind of do it all in the background and pull both data sources together so that we can map things out. And we have a research team that's been able to use that within the research data warehouse. I'm learning all these, IT terms, but we are trying to do it more from the enterprise data warehouse, which is all of the front end clinical and billing data. So we kind of want to mirror what they're doing, but have it to be able to be used more for operational needs than just research needs.
Definitely. Okay. Anybody else have anything to add? Okay.
Don't really have anything. It's a challenge.
Yeah. Definitely. Karen, has anyone in the chat shared their thoughts or experience on the concurrent versus retrospective data, or even cleaning up the data, anything like that?
They have not. So, but if you guys have ideas, we want this to be interactive and open. So if there are registrars out there that are figuring some of these things out, please comment in the chat, share, or if you have ideas, we'd love to share it.
I did just see, I'll pull this up, Karen, sorry. Hello, other Aaron again. Will this webinar be available to review after it's live? So much great info and I want to take better notes. I know we're doing a lot, so sorry guys, but this will be available as a video. The live will be available on our YouTube channel at Registry Partners. It's just Registry Partners on YouTube. And we do have a playlist specifically for the Registry Exchange. So this episode and the last episode are both on there, and those will stay on there. So the QR code and everything, you'll still be able to scan it at a later date, or if you have administrators or colleagues that weren't able to make the live that want to watch it, it will be housed on YouTube for you all to reference later. So that is a great question. Okay, so we've been talking a lot about data quality and how concurrent data supports those clinical improvements, as we know. But another important area I want to get into where registry data can make a big impact is financial and strategic decision making. So we do have the poll on how has registry data at your facility helped justify these various things. So we do have a good portion say new oncology services, along with program expansion or new hires, which is wonderful. Another big chunk for capital purchases like equipment, and then a few of we haven't used it that way yet or not applicable to my role. So this is all great to see this much this data being used for some of those. So to you all on the panel, have you seen registry data directly shape any financial or operational decisions at your facilities?
I'll jump in.
Go ahead,
yeah,
Erin.
so we absolutely use the data to help with making some of these financial and operational decisions. So we use analytic case volumes to help determine strategic programmatic growth. This ranges from surgical slot advocacy, new equipment for biopsies, hiring additional providers, and a lot more. We also use it to determine our areas of strengths and weaknesses in collaboration with our marketing data. This also helps, or it also helps when we inform our executive, like president, CEO, et cetera, in terms of helping to determine our company direction and how they're going to prioritize our work within our cancer service line in with the rest of our healthcare organization.
Yeah, I mean, Erin said exactly what we do here with the data. I have a very recent specific example in that our upper GI data that we kept providing. I mean, I provide monthly updates on it, and it was showing that we had these upper GI cases, but they were all class 0-0, so they were all leaving. So what can we do? You know, of course, we're looking to grow the program, growing the facilities. So that data was used to go and recruit an upper GI surgeon, and she actually just started the last month, and we've already performed the first upper GI surgery on a cancer patient. So it was a huge win.
It's a great example.
Definitely. It looks like Kathleen, she's over on LinkedIn. She's used their data for new hires and adding an FTE in-house, which I think is one of the biggest ones, just really showing where those open opportunities are. But do you guys have any examples of maybe where the analytics led to a tangible improvement in patient outcomes? Leslie, did you do anything at Franciscan?
Yeah, so we actually use it, our QI initiatives, 7.3, but it's been using turnaround times. And specifically, we've been focusing a lot on lung cancer lately and from diagnosis to treatment, and comparing that to the National Cancer Database average. And some of the facilities weren't where we would like to be. So we took that data, we worked on it, and came up with root causes of why our turnaround time was so extensive, and have taken that to make improvements. So, one of the root causes had to do with IR biopsies and how long that was taking. So we worked on that, and the patient flow issue has since been improved, and our turnaround time is decreasing.
That's great. Anyone else have anything to add? All right. Well, time is flying. We only have about 15 minutes left, so I'm actually going to skip some of the discussion for equity and bias. It's a little controversial, but maybe we'll come back in a later episode to touch on that. But beyond some of the challenges you guys have discussed, there's also incredible opportunities for growth and innovations in registry work. And to get a sense of what's sparking the most excitement for our audience, Karen, we have the poll. What innovation are you most excited about in cancer registry work? And of course, you guys too in the audience, if you want to let us know. We have 35% for real-time analytics, definitely exciting. 30% for AI or natural language processing for data collection, integration with EHR systems, which Laura has talked a little bit about, and then a few responses for not sure and expanded survivorship. So this is all great. What about you guys on the panel? What innovations or analytic tools are you guys most excited about or currently exploring? And actually, I'm going to call on Laura first because I want her to talk about the data lake, which is super exciting.
Sure. Yeah, I mean, I think all of the tools are really exciting. And before I get into the data lake, I think, natural language processing and AI are going to be huge improvements to finding those pieces of information within the chart that are not discreetly documented that we all want to know. So I think that's going to be really cool. And we actually do have a provider. He's a breast surgeon. He's also specializes in genetic testing, and he's a huge researcher at our organization. And he has used some of these tools and a lot of other things that are, again, kind of outside of my realm here, to create a data lake. And so what he's doing, and I'll show let's see there. Oh, is that the new one?
Yep, Karen's got it for you.
Oh, great. Okay, perfect. So this is his data lake that uses, and you can see the tumor registry information is down in the bottom left there. So he uses tumor registry data to help identify patients with cancer for various studies and quality improvement efforts. But he also uses that data and links it to family history data that's captured in the breast imaging database, as well as in the genetic testing data. And we have a separate genetic testing database, which pulls from 4 different companies. So all of the send outs that we do, he gets all those results back and puts them into one place. And so he has, he's got 6 different databases that on their own, provide a lot of information. But what he does is pulls them all together to help identify patients who need genetic testing, but have never had it done. And then it also provides the contact information for those patients because it's, lives in another part of the data lake in another source. And then that team reaches out to those patients to try to contact them and get them tested. So it's a really cool process. And, you can see just here all of the different data sources that are pulled together. And a lot of those, I guarantee there's some AI, and I know for sure there's some natural language processing happening as they sift through all of the different data sources.
That's really exciting. I know for me, I didn't even really know what a data lake was until I started working with you, Laura. So to see all of the various registries and data housing come together is really exciting. Leslie or Erin, do you have any other tools that maybe you're excited about or currently exploring?
Not so much for me. We were in talks with other registry software programs in terms of how they're integrating a little bit more with the EMR. But outside of that, I'm 7 months into my role, so I have not had the opportunity yet to really
Sure.
understand the AI marketplace and what could be eventually brought to Corewell Health. But it's exciting that it's happening, and it's all fast and furious.
Definitely.
Yeah, we also have not started exploring anything just yet. The questions are just now starting to arise, and NCRA conference, I took a lot of notes in prep for it. A lot of the interfaces. I mean, we have the basic interface right now from our EMR to our registry software, but if we could get a lot more of the data fields over, that would help save time to where all we have to do is do a QA check on it. So that's something that I am excited for, and hopefully the near future. But I also know how slow things can move at healthcare facilities.
Definitely. Do you guys have any thoughts, or how do you see maybe technology that's emerging or continuing to shape the way that registry data is used, like through AI or NLP, Power BI, anything like that?
I think the advanced analytic tools like Power BI are going to make the registry data more accessible. Like we mentioned earlier, registry data in and of itself and the different softwares that we have are not the most like user friendly for non-registry people. So I think being able to use some of these tools will help make the registry data more accessible and relevant, not only to like the clinical user, like our physicians and nurse leaders, but also to, you know, the administrative leaders as well, the cancer center directors and administrators trying to make strategic decisions.
Definitely.
Yeah, I
Anyone
agree
else?
with that, and it also leading to more concurrent information. It'll just help with that.
For sure.
I'm just excited about the potential even just to improve the efficiency and
Mhm.
hopefully decrease the workload on our team. I know it takes a lot of time to do. We're pretty manual over here still with our cancer registry software. So I'm very excited for what is to come, hopefully in the near future.
Yes.
Definitely like getting some of the case finding imported, follow-up imported. And for me, I know, again, along with the term concurrent, the term AI sometimes makes registrars a little bit nervous, but like you had touched on earlier, Erin, until really the entire medical record is full of discrete fields, I don't see AI fully taking our job at
No.
all.
I don't think so either. It's just going to make it more efficient. I mean, really into Leslie, I think you were the one that said focusing more on like the quality point of it and making sure that we're just validating the information that's getting pulled over. That alone, and gosh, the case finding, I just hope that we're finding all the cases in our EMR, because that alone is just so tricky to track down if you're not in a good place with pulling that information out. So I'm just excited about the potential. And again, it's more just about making things efficient for team members so that we can get more concurrent data, to your point. So exciting stuff on the horizon.
For sure. And even relevant to this, so we have someone on LinkedIn, as long as the technology, AI in this case, augments that workflow instead of replacing those currently performing it, it can definitely enhance the discovery phase, the fact finding during abstraction if used properly and with the right intent. And I definitely agree. So thank you for that comment. Anyone else in the chat at all, Karen, or are we pretty caught up?
I don't see anyone else in the chat, but I think the presentation today, also talking about AI, explains the fact of why learning data analytics and reporting is so important to a registrar's role. As more becomes automated, it's going to provide more opportunity for us to utilize the data and help administrators, physicians, people throughout the health system make, those decisions based on our data.
So with that, oh yes, good to know about job security. I definitely agree. And I mean, even AI now, asking it questions or helping write an email or something like that, it's making mistakes. And so it really will need kind of a registrar or a human on the back end to make sure that quality is there. So we have a couple of minutes left and we have our final poll question. What is your biggest barrier to using registry data more effectively? And the big one, which I think we all can agree with, is lack of time or staffing. We have another good chunk, 25%, not sure where to start. Hopefully after this conversation, you have an idea, but also we'll throw those resources up there again too with some of the Excel, free Excel courses, and then also the data visualization information. Awesome. Thank you, Karen. 15% we're using it effectively. And then lack of leadership buy-in and technical limitations, which I think we definitely have all been there as well. And these barriers, all of them are very real, and they also highlight why collaboration is so important, and overcoming them often requires different perspectives. But with that in mind, how can researchers and clinicians collaborate more effectively using these data sets? I'm going to go to you, Laura.
Sure. I think that really it's just more integration with operational data for us. Just being able to link appointment data, clinical outcomes, subsequent treatment data, And I think that's really important in the academic medical center, tertiary quaternary care centers, because we are getting a lot of those patients beyond their first course of treatment, but we still want to know a lot of the same information that the registry collects. So being able to kind of combine all of that together.
Great. So we're wrapping up here, just a few minutes left, but I'd love for each of you guys on the panel to share one key takeaway for the audience, something they can keep in mind about maximizing the power of registry data analytics. So we'll bounce from Leslie to Erin, and then we'll end with Laura.
All right, so I would say provide examples of the data that you do have, because again, very few know what's available. But once you start sharing, just be ready to expect more and more requests to come through. And along with that, again, make sure the data is of high quality. That's the top priority for all of your abstractors, because the data, once it's starting to be pulled, it is going to be put to use, and you don't want people to make big decisions on inaccurate data.
Yeah. My follow-up will actually be a little bit of the poll. So that 25% of people who said they don't really know where to start. Being new, like I said, to this space, everything can seem somewhat overwhelming and really hard to know where to start. So take the time to learn, read journal articles, go to conferences, network with different people and different facilities, and just soak in all of the information. Get involved in some of that strategy work at your organization, ask questions, really start collaborating with your directors and VPs, and just start small and see how you fit into the bigger picture, and never be afraid to ask questions.
Definitely.
And I think the only thing I would add more on the logistical side is making sure you have good IT support, really trying to advocate for that, because I know it's a precious resource everywhere. So really trying to advocate for that. And then also, I think it's really important, what I've seen on our team is having a mixture of team members who understand both registry data and clinical and operational data, so that you really know how to marry the two together. And Deb.
Yes, definitely. Yep.
Deb's point is great.
Be able to defend your data, definitely. Know where it's coming from, know how you pulled it, why you pulled it. That's really one of the first things we learn about data analytics, is being able to kind of justify how you got the numbers to where they're showing in your pivot table or your graph or whatever. Because the first thing people are going to do is start asking questions. Well, this doesn't seem right. I've experienced this. Well, they may not have seen it in numbers, so they could have the mindset that I stage 100% of the time, but maybe you don't do the full TNM stage in the record. That's one of the biggest kind of not really arguments I get with physicians, but it's like, we're doing this, and it's like, but the data's not showing it. So how can we work together to kind of increase that data and maybe make that even a quality initiative? So we have 1 minute. So Karen and I want to thank our panelists, you guys, for sharing such valuable insights, and all of you guys in the audience for your engagement throughout the discussion. This was great. We covered a lot of ground, and we hope that you're leaving with new ideas about how registry data can support patient outcomes, strategic decisions, and even some equality in care, even though we didn't touch too much on that. And we do have the resources, again, the QR code on the screen. So it's a short list of free learning opportunities for building skills in Excel. It's actually a LinkedIn article, along with a practical guide that I created for you all on which visualization tools work best for different types of registry data. So Karen, do you have anything to add before we log off?
Just thank you all for your time today, and also reach out to your software vendors. They should be able to help you get started. If you're not comfortable using some of these things, they can help guide you with how to run some reports and get you started there. So thank you all for joining. Thank you for being involved today.